So in the next 45 minutes I'm going to take you through a bit of a whistle-stop tour of my research post-PhD, so from my first postdoc. For those of you who don't know me, but not many people here, I'm Susan Clarke, and I started about 18 months ago in the School of Nursing. And I work very closely in a group called the Biomaterials Research Group, which is based over in engineering, and it's just an umbrella group for anyone who has an interest in biomaterials at Queen's. So if we think about regenerative medicine and tissue engineering, then really we have ideas of Frankenstein headlines, and in particular the very famous ear on the back of the mouse. And actually that's not too far from the truth. That is really what happens. There have been some success stories. Recently there was a trachea that was grown ex vivo, so outside the patient, that was seeded with the patient's own cells and then reimplanted in a hospital in Sweden. And there's also been some successes with growing miniature kidneys and livers in the lab, although obviously not ready for implantation yet. But there have already been some ex vivo generated organs that have been implanted back into humans. And the premise and the promise of regenerative medicine and tissue engineering is that they'll be able to grow spare parts for whatever tissue or organ that we need replaced. There will be a protocol that can be followed that will grow that tissue part. I think they're probably on their way to being able to do it for mice, but a good still long way away from being able to do it in humans just yet. If we look at the tissue engineering paradigm or the protocol for tissue engineering, it's based on extracting cells, so stem cells that have the ability to form lots of different tissue types and different cell types. Ideally, we would want to take these from the patient themselves so that they were autologous cells, but that's not always the source of these stem cells, and we'll look at that in a couple of slides. So these cells are removed and they're grown up ex vivo in the lab, they're expanded in culture, and then they are added with growth factors onto a 3D matrix or a scaffold, which is going to provide the shape of the organ. Then they're cultured again through a second culture period and then implanted back into the patient. So you can see that it looks quite simple in a diagram, but it's fraught with difficulties and with problems, and also with regulation, because you're taking something outside the patient, manipulating it and then putting it back in. So if we focus just on this section here, the triad, tissue engineering triad of autologous stem cells that are going to be able to form the different tissue types, growth factors, and a scaffold. So as I said, where are we going to get these cells from? There are lots of different sources of stem cells, some more controversial than others. Obviously the most controversial being embryonic stem cells, which can be taken from the 5-day inner cell mass of a blastocyst or a developing fetus. And those cells are totipotent, which means that they can form any tissue type at all in the body, any cell type. And that makes sense. It's a 5-day-old embryo. It needs to be able to make every part of a human body that it's going to grow into. So those cells are totipotent. There's also lots of fetal tissues that we can get stem cells from, and we can get stem cells from umbilical cord blood. In the adult, we have lots of stem cell sources, but they're not totipotent stem cells, which means that they already have some sort of differentiation happen to them, and they can't form any tissue in the body. They can only form specific types of tissue. So they can form a few, but not all. And so they're called multipotent rather than totipotent. So the places where we might get them in adult tissue are mostly from bone marrow, fat, from periodontal ligaments, from skeletal muscle. So there's a few sources of them. And these cells can grow into different types of cells, which will then form the basis of the tissues ex vivo. So the cells that I use in my research are bone marrow stem cells. They're also sometimes called, and more correctly called, bone marrow stromal cells, because you know that in the bone marrow compartment we've got the hemopoietic stem cells, which are the ones that make all the blood cells, and they're the ones that are transplanted for leukemia and lymphoma patients. But we also have this other organisation of support cells, which in the past, that's all they were described as, was support cells. But they've now discovered that these support cells, actually 1% of them are mesenchymal stem cells that can form blood and fat and cartilage and bone. So these mesenchymal stem cells are a very small population of the bone marrow stromal cells, just about 1%. And they contain the ability to form bone, to turn into osteoblasts. So the way that we look at them in the lab, there's no one marker that the cell expresses that says, hey, I'm a stem cell, that we can label. So what we have to do is guess and infer if it's a stem cell or not. And the way that we do that is that we put the cells into culture quite sparsely and we let them grow for a couple of weeks. And if it's a stem cell, it grows really fast in one spot and it forms a colony. So each one of these dots is from one single stem cell. So we can count the number of dots to get the number of stem cells that are in the sample, and we can measure the area, and that will tell us the ability of the stem cell to proliferate, so the stemminess of it and how fast it wants to proliferate. So how does regenerative medicine and tissue engineering apply to bone? Well, actually, bone has an innate capacity for self-renewal. And this, obviously we're all aware of this because everybody's broken a bone, or most people have had some sort of skeletal injury which has repaired without too many problems. And also, just as we're sitting here and as we're walking about and running and just living our daily lives, our bones are subjected to stress that causes very tiny fractures in the bone, and these cracks need to be repaired all the time. So our bones are undergoing a constant cycle of renewal and repair. And so it's a very well regulated and well run machine, this bone repair. And it starts off with cells called osteoclasts, which come along and eat out the bit of damaged bone. So they understand the signals and know where the damage is, and they go along and they burrow it out and take out the bit of damaged tissue. Then the signals that they leave on the bone tissue where they've eaten it away signal to osteoblasts, which are the cells that form new bone, to come along in behind and to make new bone matrix. So initially this new bone matrix isn't hard, it doesn't have any mineral in it, it's soft, and then with time the bone will become mineralized and the normal tissue architecture is returned. So this is a really coupled mechanism and really tightly regulated. You need the osteoclasts in order to leave the signals for the osteoblasts to come in behind and form the new bone. So if we just look at that on a wee diagram or a wee cartoon. So there's the microcrack, and you can see the osteoclasts, so the big fat cells with lots of nuclei, that they come in behind and eat out where the fracture has occurred. And the first thing you'll notice is that they take out a much larger area than they need to, than where the fracture is. And then the osteoblasts are the little cuboidal shaped cells, and they follow in behind in the same way that the osteoclasts have dug out. The osteoblasts come in behind and start to secrete new bone. So the new bone initially is unmineralized, it's orange, and then it gets hardened and becomes green and returns to normal architecture. So you can see that the bit that was eaten out has been exactly replaced by new bone. This can become deranged, for in fact, like in osteoporosis, the osteoclasts eat out more than the osteoblasts put back in. So over time you get a net reduction in the amount of bone, and that's why people with osteoporosis are more likely to fracture a bone. So if bone has this innate capacity for renewal and repair, then why do we even need to help it? Why do we need to apply regenerative medicine to bone tissue? And it's because there is a finite capacity for how much new bone can be formed. So it'll be able to repair a very fine fracture. But if for some reason you need to remove a lot of bone, or if for some reason that fracture doesn't heal, then the bone repair mechanism becomes exhausted before it's totally filled in the bone defect. So there are a number of orthopaedic challenges which result in quite a large bone defect. The first being delayed and non-union of a fracture. So you can see the fracture site here, and even after 6 months this fracture is still very visible. the bone healing process has been exhausted. There's no more new repair going on there, and yet the bone hasn't been fixed. So the surgeon's going to have to do something to that in order to re-stimulate new bone growth to try and get it to repair. The second indication would perhaps be in tumour resection. So this is a tumour in the proximal ulna, and you can see that there was quite a large area of bone that had been removed there that had to be filled with something, and then an external or an internal fixation device applied. One of the big problems for which require a lot of bone graft material is in revision arthroplasty or revision surgeries. So what happens, this is a primary hip implant, so this is the first hip replacement that the patient's had. And what happens is that with time, bone gets removed from around the edge of the implant. So you can see the slightly darker grey around the edge of the implant. That's where bone has been lost, and the osteoclasts have removed a lot of the bone. And so the implant becomes loose in the socket, and it has to be taken out and a new one put in, and it's called revision of the joint replacement. So when the surgeon removes that implant, he has to remount all of this damaged tissue. So you're left with a huge hole that has to be filled in with something before, like grout, before the new implant can go back in. So that's a big use of the bone graft material. And finally, it's used in spinal fusion. So if someone has a prolapsed disc or some sort of degenerative back changes and a lot of pain, then one way that they can try and reduce the pain for the patient is by fusing two vertebrae together so that you have less movement at that joint and it reduces their pain. So what they have to do is pack something into this intervertebral space that will cause bone to join the two vertebrae together and not allow movement. So you're trying to get bone to grow in a place where it doesn't usually grow. So what do they use at the minute for these bone grafts? Well, the ideal situation would be to use autograft, to use the patient's own bone, and that is usually harvested from the iliac crest and the hip. Now there are a number of problems with that. Obviously there's a limited supply. You have very little amount of bone that you are able to take out of your hip. So if you've got something like revision arthroplasty, it's really not going to be applicable for that. You can't get enough autograft to fill around the implant. And the other problem is that the patients report more pain from the hip than they do from the original injury. So there's significant patient morbidity at the donor site. So the second option is to use allograft, which is donor bone. And this is quite often the femoral heads from joint replacements. So people donate them and they're stored in a tissue bank. Again, there's a limited supply. Also, it doesn't work as well as autograft does, so there's a clinical failure rate of about 30%, and they're concerned about disease transmission, so especially with the transmissible and spongiform encephalopathies like BSE. So there is a need for an off-the-shelf synthetic bone substitute that we can use instead of autograft and allograft just to pack these big spaces in the bone. And if we look at the composition of bone, there's two types. There's cortical or compact bone, which is solid, and then there's cancellous, this open, more porous structure of bone. And both of these types of bone have two phases. There's an inorganic phase, which is calcium phosphate mineral, specifically hydroxyapatite, and there's an organic phase, which is 95% collagen. So this hard mineral, the calcium phosphate mineral, and the collagen are both essential for the bone, and they provide bone with its toughness and its hardness. So when the material scientists decided to develop a synthetic bone substitute, they took inspiration from the normal architecture of the bone, the normal makeup of the bone, and all the synthetic bone substitutes that are available on the market at the minute are some form of calcium phosphate. So they're ceramic materials. They're not all hydroxyapatite, but they're some form of calcium phosphate mineral. That's an example there, just of one of them, of the particles of ceramic that would be used to pack these spaces. These synthetic bone substitutes are osteoconductive, which means that they support new bone growth across their surface, but they're not osteoinductive, so they don't drive new bone formation, they don't stimulate it. like autograft does, and so they've all provided inferior clinical results compared to autograft, which still remains the gold standard. So what we want to do is enhance the bone substitute. And so we're taking inspiration here from our tissue engineering triad, which uses cells and the material and growth factors in order to create the new tissue. And working in this area are both biomedical scientists and materials scientists. So being a biomedical scientist, then the approach that we took was to add a biological element. We wanted to add an osteogenic or an angiogenic element that would stimulate new bone formation. So we could do this by adding growth factors, or by adding bone marrow, or by, more recently, by adding culture expanded progenitor cells or stem cells. And so this is the work that I'm going to present in the next few slides. So my first postdoc position was at the Orthopaedic Research Unit in Cambridge, there we were interested in trying to add growth factors to the ceramics in order to try and stimulate new bone formation. The work was funded by the Wishbone Trust, that's our wee logo there. And specifically we were interested in applying this to revision arthroplasty. So the first thing that I had to do was develop a model of revision arthroplasty in a rat. So we have our Sprague Dawley rats, and what we did was use a stainless steel pin. So we have a stainless steel pin here that we put into the proximal tibia. So we're simulating a knee replacement. So it goes into the top of the knee, press fit into the top of the knee. So before we put it in, we created a defect around, just under the head of the pin and around the pin, which we packed with tricalcium phosphate particles, so ceramic particles, with a similar mineral to bone. So we've got here this is our simulation then of revision arthroplasty. We'll have the implant with the graft material packed around it. And then on the graft material we had absorbed different growth factors. So group 1 had no growth factor, just the material itself. And then we used transforming growth factor, insulin-like growth factor and basic fibroblastic growth factor alone and in different combinations to see if we could stimulate faster bone healing in that defect site. So at 3 weeks, this is the pin here, this is the shaft of the pin, and here's the head of the pin. Here's the defect site that we created, filled with the particles of beta TCP, all the dark blobs. And you can see that at 3 weeks it's quite a disorganized tissue, it looks quite messy. If we look up close, this is shadow here is a particle of the ceramic, and these blue stained cells on top are actually osteoclasts, which are starting to resorb the ceramic. And then if we look down below here, these cells that are lined up along the bone, these cuboidal cells, are the osteoblasts, which are starting to lay down new bone. So this very dark seam of material is unmineralized new bone, and when it becomes mineralized it stains white. So you can see from this evidence that the cells and the body are treating the ceramic particles the way that they treat bone, and are resorbing it by the osteoclasts and forming new bone on top of it. At 6 weeks, we've lost a lot of the particles, and we're starting to get a bit more organisation in the tissue. We're still seeing osteoid, or the new bone, and the osteoblasts making the new bone, and we're still seeing osteoclast activity. In this image here, we've stained the osteoclasts with a specific dye to label them red so that they're more visible. And then by 26 weeks, you're getting re-establishment of the trabecular bone, so the porous, the trabecular struts in the tissue, and we're getting clear marrow islands, so we're getting much more re-establishment of the normal architecture. We're still getting some bone remodelling, but here you can see this is a solid particle which is still there. It doesn't look like it's been touched at all, and it's got a shell of bone the whole way around it. So that's going to remain there. Now there's no more osteoclast activity around that, and that will remain there until it gets replaced in the normal bone remodelling cycle. It could be years before it would be replaced. So we can put some numbers to it. That was many a happy hour sitting at the microscope drawing round tissue and quantifying the amount of ceramic that was left in the defect site, and the amount of bone and the amount of marrow and fibrous tissue. And what we found was that with the basic FGF, there was a reduction in the area of the ceramic that was left. And we also looked at the particle size and the particle number, and we found a reduction in the size and the number of the particles that were left, but only with FGF, and there was no difference in the amount of bone. So there was no effect of the TGF, no effect of the IGF, and the basic FGF only reduced the amount of ceramic that was left and didn't actually increase the amount of bone. So I'd say there's limited success there in improving the bone healing and having any effect in that model with those specific growth factors that we looked at. So we go back then and think about our tissue engineering triad. We've looked at the growth factors, and now we wanted to look at then the cells, and would we get better results if we used osteogenic cells in the defect site rather than the growth factors. And so that was my next postdoc position, by which time I'd moved back to Queen's, and I was at the trauma research group in Musgrave Park Hospital up the road. And this work was funded by Smith & Nephew, an orthopaedics company. And they had a new material called the Advanced Jax Bone Void Filler System, which was a bit of a mouthful. But they had these granules, ceramic granules, that were shaped like the Jax, you know, the Jax game, the kids' game, and that's why it was called Jax. And it was a bone void filler system because it came with carboxymethylcellulose gel, and it was just in order to mix the two together, and the gel just held the granules in the surgical site for implantation. So we did a number of studies with this. We tested them in vitro. So we looked at the cell attachment to the granules and we looked at the effect of the gel on cell number and on cell differentiation. And I'm not going to show you the details of that in vitro work today, but we just to say that we were able to show good cell attachment from a number of cell sources. So we used rabbit bone marrow derived mesenchymal stem cells from human bone marrow, and osteoblasts grown out of human bone explants. And we got good cell attachment from all these cell types. You can see them here on the surface of the Jax, well spread out and happily proliferating away. And by day 14, they completely cover the surface. So they do migrate over the surface and they do proliferate. So after we'd done the in vitro study, then we did another in vivo study, this time in rabbits. We're moving up the chain. So we used New Zealand white rabbits. I had a 1.5 centimetre ulnar defect. So it's a cortical defect this time. And we just basically make 2 cuts in the ulna and remove the whole section. And then that defect site was filled with 20 of these Jax granules. So we had 6 treatment groups, not 20. We had just the granules alone, and then we had 2 groups that received cells from the rabbit's bone marrow grown up in the lab. One of these groups got the cells injected on top of the Jax at the time of surgery, and in the other group we pre-cultured them for a couple of weeks so they were already attached to the ceramic before it went into the defect site. And then we had 3 positive control groups. We had the Jax mixed with bone marrow, we had the Jax mixed with VEGF, which is vascular endothelial growth factor, and we had an autograft group, which was just the cortical bone taken out, turned upside down and put back in again. So some results from that. These are the x-rays at 8 weeks. We've got the Jax alone group, just the particles, and you see it okay in that light? There's a little bit of bone. There's a little bit of bone in between the particles, the ceramic particles in the defect site, but not that much. And if we look at the histology, this is the original 2 cuts on the ulna. This is the underlying radius. The gaps, the holes, are where the Jax granules were, and then the purple is bone. So we're getting some new bone in the middle of the defect site there. If we look at the VEGF, look at that, isn't that lovely? It's like completely restored. You can still see the particles inside the bone, but the normal gross architecture of the bone has been re-established, and that's confirmed on the histology. So we've got bone in between all of the particles, but the particles are still there. And then the cell groups were somewhere in between. So we got more bone than we did with the Jax alone, with the granules alone. but we're still seeing significant islands of fibrous tissue, this light pink tissue, which hasn't become bone yet around the particles. And again, lots of counting and histology later, then we were able to quantify that, and we found that for the Jax alone group, so the one that got untreated, there was about 30% bone, 30% remaining Jax, and 30% connective tissue in that defect site. We got an increase in the amount of bone for the bone marrow group and the VEGF group, but interestingly, there was no reduction in the Jax volume. So the ceramic stayed there. So even though the tissue is happy to treat it as self and to form, the bone's happy to form on top of it, we weren't getting any resorption of those ceramics, so it's going to be there for a long time. So adding bone marrow aspirate or VEGF to the Jax greatly improved the healing, but adding the culture expanded stem cells was only marginally better than the control. So we've shown that really in our previous study that growth factors weren't really enough to stimulate the osteogenic growth factors, and now we've shown that the cells really weren't quite enough to stimulate. So maybe you do need this triad, you need the cells and the growth factors and the scaffold in order to generate this new bone. What we're really trying to do is find where the limit is so that we get the minimal amount of intervention. You don't want to over-engineer something that in a tissue that's already capable of healing itself. You just want to find the level of giving it that prod to get it to heal. But if the cells don't work, and they didn't work particularly well in that case, is it because you saw the error bars on those graphs? And everybody in here is aware of the patient variability, the interpatient variability in anything that we measure. And we find the same thing whenever we're looking at rabbits or rats or whatever in our in vivo studies, that the inter-animal variation is huge. So could it be that there's maybe a subpopulation of people that this cell therapy would be appropriate for? And so based on some of the previous reports in the literature which suggested that there's an age-related decline in the stem cell population. So RFO suggested that there was a reduced colony size, so that's the stemminess of the cells, that they can't proliferate as much as we get older, the cells don't proliferate as much. And Muschler suggested that they don't have the ability to form bone, so he looked at a specific marker called alkaline phosphatase, and he found that there was a reduced expression of this marker in females with age. And then Hernigou found that there was a reduced number of stem cells in women, and that he was able to relate the degree of healing that he saw in the fracture site with the number of stem cells that he found in the bone marrow. So there could be some patient factors that might be at work here, and we might be able to find a population of patients for this stem cell therapy that it would be applicable for. So another project then that we were involved in, Rosalie McCann did this for her first postdoc after her PhD, and again it was funded by Smith and Nephew, and we were looking, trying to repeat the results that had been presented in the literature and seeing if there was any other factors that might affect the bone marrow stem cell compartment. So we took bone marrow aspirate during total hip replacement from 38 patients, 22 females and 16 males, and we looked at the age range, which was from 28 to 91, and the body mass index range, which was from 21 to 38. And we measured the number of stem cells using this colony forming assay. So we grew them up in culture and then stained them so that coloured them with the dye so that we could count the number of stem cells and also the area of the colonies. And we looked for expression of a few specific markers, but I'm not going to talk about that today. So what we found was that this is the total colony number. So this is the total number of stem cells in our bone marrow aspirate, and this is age, increasing age. The blue line is male population and the green line is female, and the black line is the total population. So there is a reduction in the number of stem cells with age, but it wasn't significant in our sample. We only had 38, it's quite a small sample. And also we had all adults. Our age range was from 28 to 91, and in some of the previous literature they included adolescents. So I think there's probably a bigger jump from children to adult than there is in the adult population. But more interestingly, what we found was that there was an increase in the number of stem cells with an increase in body mass index in males. So the female line was pretty static, but the male line was a pretty sharp increase in the number of stem cells. And if we look then at the colony area, so this is the stemminess of the stem cells and how good they are at proliferating. Again, we saw a bit of a decline with age that wasn't significant, but we found an increase with BMI just in the male population. And if we look at the number of these cells that can form osteoblasts, by looking at this alkaline phosphatase marker, then there was no significant change with increasing age or with increasing BMI. So there's an increase in the stem cell population in males, there's an increase in their ability to proliferate, but there's no difference in how many of those cells go on to form bone. So we sort of confirmed the reduction with age. I think it is due to the fact that some of the other populations had children included in them. But we found this new thing, which was the link with BMI in males. And it also reinforced what a few other people had found, in that there's gender differences in the stem cell compartment and in how males and females respond to different external stimuli. So I think it's a new avenue of research that we could follow. So if we go back then to looking at how we were going to improve bone healing by enhancing the synthetic bone substitutes, I've described how, as a biomedical scientist, we took the biological route of adding the osteoinductive element, but we also work quite closely with engineers, and they weren't sitting on their hands during this period and not doing anything, and they were trying to enhance the material design by manipulating the porosity of the material and by manipulating the micro and nanostructure of the materials. And the reason why they introduced the porosity is because we've already seen trabecular bone isn't solid, but you've seen from my two previous studies in the rat and in the rabbit that what we were implanting were solid particles. So the osteoclast would be able to resorb so much, and then they'd get a shell of bone around it, and that would be it, and it wouldn't get eaten anymore. So the material scientists then decided to take inspiration from nature and to start developing porous materials. And one of the key inspirations was from coral, which is a mineralizing marine creature which already has the porous structure. And so coral was first used as a bone substitute in the late 70s, and there are a couple of commercially available bone substitute biomaterials that are based on coral. But coral isn't the only marine organism that has a mineral structure or has a porous structure, and there's a whole wealth of these creatures in the marine environment just waiting to be mined, and they range from pores on the macro scale like cuttlefish and sponges, to the micro scale like this mineralizing red algae, which is a seaweed, and to the nano scale. This is only 1 micron down here, this scale bar. So these are coccolithophores, which have a silicaceous little shell, little skeleton around them. So this was my most recent work then. Whenever I was based in biology, I was funded by the Marine Institute of Ireland, Science Foundation Ireland, as part of a Beaufort scheme to look at novel applications for marine creatures. So we have a number of research projects which are happening at the minute that have this marine theme and that are using these marine creatures for bone applications. And the first one is a direct use of the marine organism itself, marine-inspired biosilica-filled adhesive complex coacervates. I'd like to say that there's a chemist working on this and that I don't understand the title either, but it's basically using diatoms, which are really tiny nanoscale seaweeds, and they have a silica skeleton, and it's using that biosilica in order to add to other parts of biomaterials to make a composite for bone repair. The second way that we can use these creatures is indirectly, and we have 2 projects in this field. We use marine sponges to create a ceramic template so that we're getting the porous template, but we're not actually using the structure of the sponge. And we also use that red algae that I showed previously, the seaweed, which has a calcium carbonate mineral, and we can convert that chemically to calcium phosphate and use it as a bone filler. So I'm going to talk about the HA scaffold, the sponge scaffold, in a minute. But finally, the other way that we can use the marine organisms is to take a part of it, a bioactive from it, and to use it as part of a composite for stimulating bone repair. And we have a few projects in this field. So the first was to use collagen derived from the marine sponge to add it to calcium phosphate cement. And that's again going back, taking inspiration from nature and from the normal architecture of bone, which has this collagen component. It's a mineral and collagen, normal bone. And so that's trying to add more of a biological element to the calcium phosphate cement. I also have a collaboration with Institute of Tralee, using fucoidin, which is a bioactive from brown seaweed, as part of a tricomposite to try and stimulate bone repair. And then the final thing is, as part of our collaboration with the Marine Institute of Ireland, they've collected a whole lot of different marine sea creatures and then chemically extracted out bioactives from these creatures. So we have a whole bank of extracts sitting there, and we'd like to screen them to see whether any of them had any osteogenic potential and could help stimulate the bone formation. And that's a PhD student that's going to start this year in October. So the last 5 minutes, I want to talk to you, just tell you a little bit about the work with the marine sponge. And this was, the material scientist working on this was Owen Cunningham, and he developed this for his PhD. And developed the material, and then I did the in vitro and in vivo testing of it. So he started off with a piece of Mediterranean Spongia garracina, and he dipped it in a hydroxyapatite slurry and then squeezed it to get out the excess, and then put it in the oven at very high temperature and created this ceramic scaffold with this porous structure. So we're using the sponge as a template to provide the porosity. And it has about 33% micro porosity, 34% macro porosity, and a total porosity of almost 70%, which is pretty good. So in vitro, we used to control a synthetic sponge, which has a much more uniform porous structure, to see whether using the naturally occurring porous material would be better than a more uniform porous material which we could create in the lab. We find when we put our cells on it, which are labelled green here, we find that we got more cells attaching to the marine derived sponge than to the synthetic sponge. And we could put some numbers on that. So the cells control are the number of cells that would just grow on the normal tissue culture plastic for that time period. So at day 4 we've got less cells on the materials than we would usually find. But by day 7 and day 14, they've caught up with the normal cell control, and we're getting more on the marine derived material than the synthetic material. If we look at their ability to form osteoblasts, so we're looking at their expression of this alkaline phosphatase marker again, there's no difference, so they still maintain their ability to form osteoblasts. And we looked at the cytotoxicity of the material, so see whether the material induced any cell death. And we didn't get any more cell death than we did with the cells alone, so nothing that we wouldn't expect to see in the cultured conditions. So these materials are pretty well tolerated in vitro. They're supporting the cells attaching, they're supporting the cell growth, and they're not causing any significant cytotoxicity. So again, we went back to our rabbit study. This time we used a cancellous defect. So you can just about see it. This is the end of the femur, and this white bit is the implant in the femoral condyle. We had 4 groups. We had 100% hydroxyapatite, so this is the calcium phosphate that's most like the bone mineral. We had 100% beta tricalcium phosphate, which is just a different formulation, and then we had a biphasic implant that was half and half. And the reason for this is because even though hydroxyapatite is most like bone mineral, it's not very absorbable, and we'll find that it's still there in years to come in patients. It's still visible on X-ray. whereas beta-TCP is a bit more removable by the osteoclast. But what we don't want to happen is that the scaffold be removed much faster than the new bone can be formed. So that's what we're aiming for. We don't want there to be any residual material at the end of the healing process, but we can't take it away too soon. So we're trying to match that formation with the resorption. So this is our autograft control. At 5 weeks you can see the margins of the defect site here, and the lighter pink struts in here are the autograft that was implanted. At 10 weeks we're starting to see some formation of the trabeculae back in the defect site, and at 20 weeks we have good normal restoration of the bone architecture. This is what we want to see in our material samples. This is what we actually see, not anything very similar. So at 5 weeks, it's probably very hard to see in this light, but the bright white, this is what I'm doing at the minute. This is current research, so I haven't finished quantifying all of this. This is just some of the image that I've teased out to show you. So at the minute I'm sitting drawing around the areas of these ceramic and the new bone. It's very difficult to see, but the bright white is the material and the slightly paler pink is new bone. So there's the defect of our margin, and you can see that there's quite a lot of material still left in there, but even at 5 weeks we're getting some new bone in here, right in the centre of the defect site with the beta-TCP. At 10 weeks there's actually good removal of the beta-TCP, and we are getting new bone in the defect site, and it's a bit more quiescent at 20 weeks, but doesn't look a whole lot different further on from the 10 weeks. And that's probably because this material gets covered in a shell of bone and it only gets resorbed so far. If we look at the hydroxyapatite, there's basically what you'd expect to see, more of the residual material at each of the time points compared to the beta-TCP. So even though it's more like the bone mineral, it's actually less resorbable. And then what we wanted to see was somewhere in between with the biphasic material, but actually the biphasic material really isn't very well tolerated by the tissue, and it seems to stimulate like an inflammatory response very early on, that we're getting this messy histological appearance. We do get bone formation into the scaffold by 20 weeks, but this early initial response doesn't really look good. So that's where we are at the minute. I'm currently doing the quantification of this histology. But what we did show in the early in vitro work was that the cells can attach to the scaffold and infiltrate the pores, and that it's possible to make these biphasic porous materials. But we need to look at the in vivo results to see which of the formulations would really be best to take forward to the next stage. So we go back then to our overall strategy of trying to improve bone healing, and we're back right at the very beginning with the triad of the cells, growth factors and scaffold. And at the minute we haven't been able to take any one of these away and still get good bone healing, and we haven't been able to match the bone healing that you would get with autograft. So there's still a way to go. And what is the future of regenerative medicine and orthopaedics? It is already possible to grow bone ex vivo in the lab, and I'm sure you've seen the headlines. So there was a collaboration between artists and scientists where people donated some stem cells, and they grew bone rings, which they then exchanged with their partner at their wedding ceremony, made from their own bone. And then with these new 3D printers, they've been able to actually print out templates for new bone. So although we can do this already, we can grow bone ex vivo, is this really the future for orthopaedics and for regenerative medicine and orthopaedics? And I would suggest that it's not, because bone has this innate ability to repair itself. So I think what we just want to do is find that trigger for stimulating it to repair itself without going through all this hassle of its ex vivo manipulation and all the regulation of it. In some cases it might be appropriate, for example a maxillofacial repair where you want a specific shape or size, but for the most part what we just really want to do is find the trigger to prod this repair. So the future for me in regenerative medicine is more in the development of smart biomaterials, which is developing materials which can have tailored resorption profiles, which can respond to the environment in the body, and perhaps increase or decrease drug release from the material. And so we could get like patient and application specific treatments and biomaterials to fill these bone defects. So just to summarise, because this was meant to be me telling you what I do and what I was interested in, then these are the summary of my research interests. So what I'd like to take forward in my research in the next couple of years is understanding more the patient factors that can affect the stem cell compartment. So to go back to the BMI and the fact that there's the gender differences and start to understand that a bit more and why that happens. And also try to relate that to predictors of whether they're going to clinically heal or not, and whether we could develop a model that would be clinically relevant. Still interested in novel treatments for bone augmentation, so that's in conjunction with the engineers, both in terms of trying to find things that would stimulate bone repair and also new materials, and controlling the resorption rate of these new bone materials so that we could tailor them for specific patients and applications. So that's it. All these people and many more were involved in this research. And just to say that the marine aspect of this was funded by a Beaufort Marine Research Award as part of the Sea Change strategy. Thank you very much.
Yes, thanks for that. Susan, that was really interesting, and it is taking me back a lot further than I ever thought I could go in terms of the lab and things like that. But I wasn't sure at the beginning, and then you've actually just come back to at the end. You talked about, patient, maybe more individualized therapies in terms of patients' genetic profile and things like that. Has there been much profiling done in terms of, I suppose, for example, in terms of people in the room where they would come from? If you think of how the overexpression of certain factors can have very negative impacts in terms of a cancer risk factor. My thinking when you were going through that was perhaps overexpression of certain growth factors could be a positive thing in terms of an ability for a patient to, in terms of autograft therapies. Has there been much work done on stuff like that?
There hasn't been any genetic profiling really to link it with the genomes. There's been some proteomics really applied to it recently. For example, people fractures will heal better if people have a head injury. So there's been a lot of work done on if that head injury has caused the release of a factor. And so before proteomics, people would just be looking at specific factors like IGF or the binding proteins or whatever. But now they've been able to apply proteomics to try and tease out which factors are released in the head injury patients that would cause more bone, but not genomics, not looking at the genetic profiles of the patients.
Just thinking from a microarray perspective, where you could pick out certain genes that be overexpressed and so that you can target them.
Not really, and I think probably because bone does have this capacity to heal itself, so it's only in a small population where there is a real problem, and it's really only now because people are interested in regenerative medicine and in using the stem cells that it's gone back to trying to understand what factors will affect the stem cells. And it might not even be to use those stem cells to apply to bone, because they can make muscle and cartilage and nerve, and so it might be to use those stem cells for other organs, to generate for tissue engineering of other organs.
It's fascinating work.
Michelle, you want to say? Yeah, I'm just interested, Susan, in the whole impact of having these biomaterials in the bone, and you're saying like the ceramic and stuff wouldn't reabsorb for a long time. What are the effects of that?
There's no effects of the ceramic, so the calcium phosphate, and it's pretty much treated like bone. And so there's no detrimental effects of that other than they have a remaining implant, and really it's more aesthetically that we would really like to be able to tailor the resorption of those. But there's lots of other materials that are used. So for example, in the joint replacements, they use stainless steel, they use titanium, they use plastic, and they use other ceramics. You can get ceramic on ceramic joint replacements, which are alumina rather than calcium phosphate, and they do have some detrimental effect. So there's concerns about metal toxicity from the metal implants, and there's concerns about some of the screws that they use in orthopaedics are polymer, and they degrade in a strange way, and sometimes they degrade on the inside and they don't degrade on the outside, so they get like a shell, and once that shell is breached they get a burst of all the product released. It's called an acid burst, and that can be quite damaging. So there's a whole lot of work done on trying to fix the resorption profiles of those polymers as well.
You said that the ceramic was initially solid, and you used the marine organisms in order to give you so you could make a kind of model of them with holes in it.
Mm-hmm.
Why did you not just use bone as the model?
Just use bone as the model?
Yeah.
Because it's on a much bigger scale. So we're trying to make it on a small. Those pores in the sponge are smaller than the pores that we would see in trabecular bone.
Right.
Trabecular bone pores are smaller, are bigger. There is nanopores in bone, but it would be difficult to once you've made the cast, it would be difficult to separate it. So at the minute, all we have to do is put the sponge in the oven, and it sinters the ceramic, so it creates the ceramic, and it also burns off the sponge because it's not mineral. So it will be hard to remove the mineral of the bone rather than removing the mineral of the template. Yeah, do you know what I mean? It would be too difficult to separate the two.
It's kind of technological reasons rather than any actual, like, presumably in an ideal world the bone design would be the best design because that's what nature's about.
Yeah.
Well, it's because it's difficult.
Yeah, and then they're trying to replicate, trying to improve on that as well, to try and because at the minute bone is designed to withstand your load and also to repair itself, whereas maybe if we could improve the porosity that would allow more cells in an initial burst to try and stimulate the repair rather than take the load initially. So maybe tweaking the function of the bone slightly.
Any other questions? Can I just ask a really naive question? And it's about Jax, the Jax scaffolding of a very interesting shape.
Yeah.
Was there any reason why they went for is there any science behind that, or is that just sort of childhood illusion?
I think they went for that granule to try and make them connect together, and then they went for granules rather than a big solid lump because of this early idea of trying to allow infiltration in between the spaces. So it's like an early form of the porosity. So rather than creating a big material with pores, they made small granules that would pack together. But then they made them in this shape so that they pack quite tightly together. So there's actually very limited space in between them. So I'm not really sure what their justification for making the 6-point thing, other than they would interlock together in the space. But because they're granules, then they needed the gel because they're not so easy to handle. But every morning when I was doing that project, I drove past the cranes, and out of the corner of my eye it looked like a Jax granule going past in the window every single morning going into Musgraves. I need to get away from this project. I'm saying that.
Well done. So look forward to
No
hearing
problem.
more as you progress. And congratulations on all the work so far. It's great. Really, it's very, very interesting stuff.
So any ideas for any collaborations?
Yeah, that's going to be challenging in relation to something.
Yeah, but I'm keen to develop the patient side now that I'm back, because I was obviously restricted in biology because we were funded by the Marine Institute, so I had to stick to the marine materials stuff really for a while. But now that I have a bit more freedom, I'm keen to do the patient predictor stuff.
But there's probably also stuff that could be done even at sort of master's and PhD level that would be more health services research related to your population group.
And also tying in the osteoporosis, and the different metabolic bone diseases and how they respond differently to the materials is something that we're interested in as well.
So I'm sure there is some link actually, it's just sort of trying to think a wee bit more laterally.
Yeah.
BMI thing as well, Susan, what's going on there, do you think?
I don't know what's going on there. Fat is the source of stem cells, but I don't measure fat. I'm still getting them from bone marrow. So unless it's something to do with, like the insulin regulation or some other aberration in the growth factors that's affecting it or whatever. But that's maybe why there isn't so much of an effect of the age, you know, because as men get older, they get bigger. And so it might be like undoing the decline in the age that they, you know, that they're getting the increase with the BMI.
Yeah.
But it would be, that's something that I really would like to follow up.